Very good evening, friends. So, we are starting a series of case discussions. And the first case that we are going to discuss is a very easy one. I'm sure everybody must have encountered such cases in day to day practice. So, this was a primary gravida who came for a routine scan, and then this finding was detected in the fetal heart. I'm sure everybody can now appreciate the finding, but these findings are very subtle, I must say, and they can be easily missed on grayscale alone. So the color Doppler drastically improves detection of these kind of defects. So this was a case of a small muscular VSD. So let's see the still images of the same. The still images also depict the VSD beautifully. We can see that we can see the VSD over here. I'm sure that you can see the VSD. This is the VSD. Then this again is a VSD over here, and then this VSD beautifully seen on the apical four chamber view, and this in the lateral four chamber view, particularly in the color Doppler lateral four chamber view, this can be beautifully seen. Then the same can be seen on the short axis views also. So this was a case of classical case of muscular VSD. So before moving on to the further discussion of this case, let's first see how the VSDs are classified. So the most simplest and the most practical classification, it divides the VSD into four major subtypes. That those are the inlet VSD, the muscular VSD, the perimembranous VSD, and the outlet VSDs. So these are the diagrams depicting the same, and these are the classical cases textbook pictures which are depicting the same. Okay, so we'll discuss about the different types of VSD in some other presentation, but this presentation is particularly for the this discussion pertains to the muscular VSD. So if we have a look again at the videos very closely, then we can see that how to detect, and I would like to give you some tips regarding detection of small muscular VSDs. The muscular VSDs are the most common type of VSDs which can be detected, which are now detected prenatally, and they can be easily missed on a grayscale image. We can see, if I label these things, this particular little defect in the muscular septum is the muscular VSD. So they can be easily missed on grayscale alone if you don't take the proper views. And I must say that color Doppler has drastically improved the detection of these VSDs, and use of color Doppler is essential in any kind of fetal heart evaluation, and only then you'll be able to detect most of the muscular VSDs. Now the tip to recognize a muscular VSD, that first tip I would like to give you is that uh, you'll whenever you see a small defect in the septum, interventricular septum, and you see that there is some septal tissue still remaining between the crux and the VSD, then that means you are looking at a muscular VSD. What I mean to say is, if I uh, you know if you if just give me a minute, if I pause this video and then if I play this video frame by frame, then you can see, whenever you'll see the VSD, this is the VSD, you can see the VSD. See, you're seeing the VSD over here, and if you look at the VSD, and this is the crux. So this is the crux, this is the apex of the heart, this is the LV, and this is the RV. And if you are seeing septal tissue between this VSD, and so this the tissue which I'm marking with green pen is the septal tissue, the normal septal tissue. So whenever you see a normal septal tissue between this crux and the VSD itself, then that means that that VSD is a muscular VSD. Because you'll in an inlet VSD, you'll never see the inlet VSDs would be located over here, that the thing that I have marked in the blue, and there won't be any normal septal tissue present between the inlet VSD and the crux. So if you're seeing a normal tissue between the VSD and normal septal tissue between the VSD and the crux, then that means you're looking at a muscular VSD and not an inlet VSD, or a perimembranous, or an outlet VSD. So this is the tip number one. And now the tip number two, if I say, look, the tip number two is, which we can see beautifully in this particular case, is the echogenic borders. The echogenic borders of this VSD. So this particular muscular VSDs, you'll always be seeing, whenever you see these VSD in apical fourth chamber view, then you'll see little echo enhancement effect. This effect is called as echo enhancement effect. There would be the tissues would be a little echogenic, just adjacent to the VSD. So this is the tip number two, to recognize a muscular VSD. So now let's move on to the other video. The same thing I have labeled over here, and that thing is, you can see the labeling using the arrowheads, and that the same thing I'm demonstrating over here, that we can see the echogenic borders of the VSD, and we can see some septal tissue remaining between the VSD and the crux, which defines that this is a muscular VSD and not an inlet VSD or other types of VSDs. So if I come on to the short axis view, they also beautifully show muscular VSDs, particularly with the color images. We can see that there is a tissue which is seen over here. This tissue, this septal tissue defect is called as VSD. This is the muscular septum, and we can always see the to and fro movement through this defect. So these are the tips to recognize the muscular VSDs. So another important thing which I would like to point out over here, that we can use the spectral Doppler also, and whenever we put the spectral Doppler in this particular over here, if we put the spectral gate over here, the sample volume over here, and then we switch on the spectral Doppler, then we'll be able to see to and fro movement through this VSD, and the movement would be mimicking the AV walls and the semillunar walls alternately. That is also a way to demonstrate the muscular VSDs. I guess that sums up of this particular case. And before I end this presentation, I must just discuss the practical working points about the muscular VSDs. And so these are the most common type of VSDs to be diagnosed internally, and they can be easily missed on grayscale alone. Color Doppler drastically improves the detection. The tip to recognize muscular VSD is that you will always see some septal tissue between the VSD and the crux, and the echogenic border of the VSD on the typically seen on the apical fourth chamber view due to the echo enhancement effect is also important to detect these VSDs. And on color Doppler, sometimes they might be missed on the apical fourth chamber view, but whenever we insonate the interventricular septum through the 90-degree angle, that is through the lateral fourth chamber view, then these VSDs are beautifully seen. I must say, these two views, particularly the apical fourth chamber view in grayscale and the lateral fourth chamber view on the color Doppler, these are the two most important sections to diagnose the muscular VSDs. And the short axis views may also beautifully show muscular VSDs, as seen in the above case. And 80% of these resolve spontaneously by 2 years of age. So we need to reassure the parents that they don't need to panic around, and many parents, they go ahead and terminate the pregnancies, and this should not be done. And that is where the counseling actually takes the main role, the main play. And these type of muscular VSDs, they are usually not associated with chromosomal abnormalities, so counseling should be accordingly. And before labeling these muscular VSDs as isolated, we should always look for other cardiac and extra cardiac defects to say whether it is truly isolated, or are there any associated anomalies. If there are any associated anomalies or any cardiac or extra cardiac defect, then you should advise invasive testing to rule out aneuploidies and to rule out microdeletions. But if it is a isolated VSD, then you don't need to investigate these further by using invasive testings. So I think this would be the end of the case discussion, and soon we would be back with another case discussion. See you all. Thank you.